So we're going to start now with our first speaker, Dr. Brent Bluett. Dr. Bluett has been at the center now for a couple of years. It seems like forever. No, actually, Dr. Bluett is a great doctor, a great expert in Parkinson's disease, and he's going to talk specifically about the intellectual and cognitive complications that can occur with the disease.
I'd like to welcome everybody. Thank you very much for coming, for battling traffic, and for being here tonight. It's good to see you all. So the name of this talk is The Cognitive Complications of Parkinson's Disease. This is kind of an under-recognized entity, and so I think it's important that we address this. So we'll discuss six different parts to this discussion. The first is a definition of what is cognitive impairment in Parkinson's disease. The incidence, which is the frequency in the population of cognitive impairment in Parkinson's disease. The symptoms of cognitive impairment in Parkinson's disease. The management of the cognitive complications in Parkinson's disease. And what is dementia with Lewy bodies? I think it is relevant because there's an overlap between the two and it's sometimes hard to distinguish. And how do we differentiate dementia with Lewy bodies from Parkinson's disease dementia? So a little bit of background about Parkinson's disease. Parkinson's disease is actually the second most common neurodegenerative disorder after Alzheimer's disease. It is the most common form of Parkinsonism. There are several forms of Parkinsonism. Parkinsonism is an umbrella term. Parkinson's disease is the most common. The diagnosis of Parkinson's disease is mainly a clinical diagnosis. This is mainly based on motor features. However, cognitive deficits in early Parkinson's disease are subtle. They may not impact everyday life. And then cognitive deficits are very common in advanced Parkinson's disease as well. So the definitions that we were discussing, so there's first PD with normal cognition. So cognition we assess in the clinic, but there's also real life. So cognition is assessed in both ways, and for something called mild cognitive impairment, it's more on the testing portion, whereas dementia is an interference with activities of daily living. So you'll see here, so PD with mild cognitive impairment, we call this MCI. And again, this is something that really is not that noticeable, but is very subtle. It's teased out more with what we do, something called neuropsychological testing, but it may not actually interfere with activities of daily living, whereas Parkinson's disease dementia does. And this becomes more obvious, and it affects your activities of daily living, driving, bathing, things of that nature as well. So in 2009, they did a study. This is looking at the incidence of cognitive impairment in Parkinson's disease. They found that 19% of newly diagnosed Parkinson's disease patients had mild cognitive impairment on formal neuropsychological testing. Now again, that's the very sensitive way to tease out these deficits. And that does seem like a high number. I don't know if you were struck by that, but I certainly was when I was looking through the literature. They found that this incidence was 2 times that in the normal population. So again, very frequent. So now they found that something called the non-amnestic MCI was the most common form in Parkinson's disease. So whereas in Alzheimer's it's a forgetfulness, in Parkinson's disease it can affect your judgment, problem solving, visual, spatial, remembering where you are in space, things of that nature. Now another study which kind of gives me a little bit of a relief is that in 2015 they redid this kind of testing. They found that only 9% of early untreated Parkinson's disease had mild cognitive impairment on formal neuropsychological testing, which is good. 21% of these patients had identified mild cognitive impairment on what we call MoCA testing. This is the Montreal Cognitive Assessment. And essentially this is a kind of a quick neuropsychological assessment, but not the formal, detailed 3-hour, 4-hour testing that is more specific. 14% of PD patients were clinically depressed versus 7% in the normal population. And the reason this is important is, along with this, there's increased anxiety and apathy in Parkinson's disease. So the combination of depression, anxiety, and apathy can actually mask your cognition and make it appear that there's a cognitive impairment, which there may not be. And this is important for us as physicians to look at and to try to address because that's reversible. So the most common cognitive disturbances in early Parkinson's disease are as follows. There's bradiphrenia, which is slowed mental processing and memory retrieval. There's also decreased verbal fluency. This basically manifests as something called the tip of the tongue phenomenon, where you just know what you want to say, but you just can't find that word. I see that a lot in when patients come in for the initial visit, and it's something that I look out for to test to see if there is a little bit of cognitive impairment. Now, 2/3 of early PD patients would have these findings on formal neuropsychological testing. Does not mean you have mild cognitive impairment. That's just a single isolated problem. So now, a study of PD patients followed from onset to 4 years after the onset of diagnosis, that found that 20% of PD patients with normal cognition at baseline did develop dementia. This is 4 years after. 18 out of 29, or 62% of patients with PD mild cognitive impairment at baseline developed dementia. And that's a very high number. So ultimately, what have we found with these studies of incidence? We have found that basically 26.7% of PD patients have PD MCI, or this PD mild cognitive impairment, that the cognitive deficits can often be detected at the time of diagnosis. These impairments can occur in a range of cognitive domains, but usually it's just an isolated finding, such as the word finding difficulty, that tip of the tongue phenomenon. And then what are the risk factors? So this is very important. Obviously, everybody here wants to know who has Parkinson's. What am I going to develop this, and what can we do about this? So older age of onset and increasing age, just as with the general population, longer duration of Parkinson's disease, visual hallucinations not related to medication, and this also brings into the question of the dementia with Lewy bodies. I'll go into this more in depth later, but dementia with Lewy bodies is actually defined, part of its diagnostic criteria is with visual hallucinations. So it makes me wonder, we have a very thin threshold for whether it's Parkinson's disease dementia or dementia with Lewy bodies, and I'm wondering in these studies, are they actually identifying Parkinson's disease patients or people with dementia with Lewy bodies? And then if it's male more than female for the risk factors for Parkinson's disease, and if there's more severe symptoms, and that essentially means that the Parkinson's disease has gone on longer, it's more advanced. So I thought this was a very useful information because really ultimately we want to make this relevant for you. So what are the symptoms of dementia that you can look for? There's difficulty concentrating. There can be memory problems, but again, that's not as frequent in Parkinson's disease as more in Alzheimer's. Difficulty learning new material, difficulty problem solving, disorientation or confusion, mood changes, for example, irritability, impatience or aggression, hallucinations, hearing and seeing things that aren't there, paranoia or delusions as well. Now, the management of cognitive impairment in Parkinson's disease, and this is very important for us as physicians to look at. The first thing I would like to do when I see somebody who I'm concerned about the cognition is, can we reverse this? Is this a neurodegenerative process, or is this something that maybe was caused either iatrogenically or by medication? So the number one reversible cause for impairment of cognition is the medications, usually the ones that we prescribe. And also depression can cause something called pseudo-dementia, where it appears as somebody actually has dementia, but it's really just a form of depression. I was talking about that earlier with that 14% rate of depression in early Parkinson's disease. Then there's delirium. So delirium and dementia, and this is something every neurologist goes through to understand, is delirium is more of a fluctuating levels of cognition and attention that happen kind of quickly. It happens over a course of a few days. Dementia is more of a long-term kind of a steady decline. It's not as precipitous of a drop. So there are various causes of delirium. So the most common is a urinary tract infection. I think probably the most important thing I could say to everybody today is the most common cause of confusion in people over 65 years of age is urinary tract infections. They do not always manifest as urinary urgency, frequency, painful urination. They simply can be confusion, disorientation. I saw it today. It's just very, very frequent. So if you do have this precipitous kind of drop in somebody who's normally okay, I think you really want to consider whether or not there should be a urinalysis and get that checked. There are other causes of delirium. There's vitamin B12 deficiency, vitamin D deficiency. Also, if thyroid function tests are abnormal, if there's hypothyroidism or hyperthyroidism, that can cause delirium as well. Now, the medications for Parkinson's disease and the cognitive side effects, every medication, it's one of my mottos. If you are a patient or see me in clinic, you know I say this every time. Every medication has a side effect. And of course, our carbidopa, levodopa, the Sinemet can cause depression, hallucinations, or psychosis. Amantadine, commonly used for the treatment of dyskinesias, can cause depression, anxiety, irritability, hallucinations, confusion, and abnormal dreams as well. Dopamine agonists, ropinirole, pramipexole, rotigotine are examples. These can cause hallucinations, compulsive behavior, anxiety. And trihexyphenidyl or artane, which is commonly used in the early stages of Parkinson's disease, mainly for tremor, can cause confusion, drowsiness, or anxiety. So you can see here the host of complications, and I always look at it as a balancing act. Is the medication doing more good or bad? And so you want to pull these off, and this is something to consider, and you just have to let your physician know when you go in to speak with them if these symptoms are occurring and if you see these medications. So now, ongoing for the cognitive management. So there is a medication that is approved by the FDA for Parkinson's disease cognitive impairment. This is called ribostigmine or Exelon. This is the only FDA-approved medication for the treatment of mild to moderate Parkinson's disease dementia. There is something called the EXPRESS trial, and this is Parkinson's disease dementia patients who were treated with ribostigmine, showed clinically meaningful improvements on 2 measures of cognition. There were secondary outcome measures as well, and they showed improvements on these. That was attention and also executive function. Executive function is essentially your decision-making, problem-solving, things of that nature. Now, the Exelon also, they showed in this trial that the improvements lasted up to 48 weeks, which is significant, and that was the length of the trial. So it was a long-acting effect. There was a little bit of decline in efficacy over time. However, the dosage can be increased. There was no worsening of motor function with this medication over the course of a year, which is very good. And it comes in a patch or a capsule. The defining factor really is one, that the smallest dose is actually only available in the capsule to start off with. It can cause some GI upset, and so usually if that happens, we go to the patch. It skips the stomach, it skips the colon and everything, and it's just a little bit easier and more tolerable. There is another medication now that's available for Parkinson's disease, specifically for psychosis in Parkinson's disease. And I'm going into this somewhat briefly. I think Dr. Bluett will probably discuss this a little bit more in the psychiatric complications. But this basically what psychosis is, it's visual, auditory hallucinations, or paranoid delusions. And now the clinical trials for pimavanserin have shown reduction in hallucinations and these persecutory delusions as well. Other antipsychotic agents that can be used for Parkinson's disease, there are things like quetiapine, which is also called Seroquel, risperidone, which is called Risperdal. They can actually deplete your dopamine and cause more Parkinson's symptoms, motor symptoms. So pimavanserin is very nice in that it does not tend to cause this. What are the side effects? Again, as I was saying, it's always a balancing act. They've been mild in my experience. The most common is a leg swelling. There's a little bit of balance problems and somnolence, but overall it's a pretty mild mild side effect profile. Now, going through non-pharmacological management of cognitive impairment Parkinson's disease, I think this is probably the second most important thing I could tell you. These are things you can do in the household and just for your loved one if they are suffering from some of these problems. You should know that operations or medical procedures, especially requiring anesthesia or sedation, can worsen symptoms. You want to monitor for sensitivity to particular medications. So if I prescribe amantadine and all of a sudden hallucinations develop, temporarily correlated, we can assume that the amantadine has caused that. You want to maintain a routine or structured schedule, kind of keep things in line so it doesn't get too frantic and cause chaos. Simplify the living area to help with distractibility or confusion. There are other things you can do. Use a night light to reduce visual misperceptions at night. Keep calm and still when talking with your loved one. Again, it's kind of the idea of keeping things nice and orderly rather than chaotic. Demonstrate your care and affection for the person with dementia. This seems obvious, but the reason is you have to keep in mind that when you're in the situation and you're the subject of paranoid attacks, false accusations, it's more of a product of the disease. It's not your loved one. Now, dementia with Lewy bodies, as I was discussing earlier, so dementia, specifically, this essential feature is defined as progressive cognitive decline of significant magnitude to interfere with normal activities and social and occupational functioning. It is prominent or persistent in memory impairment that may not necessarily occur in the early stages, but is usually evident on progression. And there's deficits in attention, frontal, subcortical. Your frontal is more of your executive function. Subcortical is your processing of thinking. And also visual spatial ability can be affected as well. Now here's really how I tend to differentiate the two, the DLB versus Parkinson's disease. The fluctuating cognition, you'll see that it's considered a similarity, but there really is a gross difference in the two. I can actually see sometimes that people, when they come in the office within an hour, in the beginning nice and alert, or just kind of drained by after 15 minutes, then back up, and it'll kind of back up and down. The recurrent visual hallucinations that we were talking about earlier, it's not frequent in early Parkinson's disease, and if you do see that, that is more likely dementia with Lewy bodies. There's spontaneous features of Parkinsonism, of course. That's the motor features, slowness of movement, stiffness, tremor, things of that nature. And then there are these supportive features, repeated falls. Falls in general in Parkinson's disease don't happen until about 8 years after the onset. Of course, there are exceptions to the rule, but in general it occurs much earlier in dementia with Lewy bodies and other forms of Parkinsonism. Syncope or fainting. Transient loss of consciousness. These are due to dysautonomia that occurs in dementia with Lewy bodies, where there can be basically difficulty with the blood vessels kind of supplying the blood to the areas they need to in the brain. Neuroleptic sensitivity. So if you were to take a Seroquel, Risperdal, one of these antipsychotic medications, instead of having a calming effect, it'll do the opposite. There are systematized delusions. And again, going back to the persecutions, things of that nature. There are hallucinations in other modalities, auditory hallucinations. And there's REM behavioral disorder. This is seen in Parkinson's, but also seen more commonly in dementia with Lewy bodies. This is talking in the sleep and acting out of dreams. Please do not assume that if there is REM behavioral disorder, it is dementia with Lewy bodies. Again, this is seen in both. And depression is more common in dementia with Lewy bodies as well. Features less likely to be present in dementia with Lewy bodies, history of a stroke, and any other physical illness or brain disorder that is sufficient enough to interfere with cognitive performance. So the similarities between the two are as follows: the cognitive profile, the fluctuating cognition, the extrapyramidal features, neuropsychiatric symptoms, the distribution. This is more of something for the scientific end, the distribution of where it affects in the brain. The cholinergic and dopaminergic deficits. In Parkinson's disease, it's presumed mainly to be a dopaminergic phenomenon. Basically, dopamine, as you can consider to be the gas you put in your car. That's what basically dopamine is for your brain. It makes your body move. The cholinergic is found to be more prominent in Parkinson's disease than we once thought, but it is even more prominent in dementia with Lewy bodies. The cholinergic system is basically mainly for attention, but also affects balance and things of that nature, which is why the falls occur earlier. Neuroleptic sensitivity can actually happen in Parkinson's disease dementia, not usually in Parkinson's disease. And the response to cholinesterase inhibitors, and these are medications that are used to help cognition, such as the ribostigmine. So now here, I think, is the most important issue for separating the two. It's called, let's see here, the 1 year rule. So basically, in Parkinson's disease dementia, what usually happens is the onset of the motor symptoms, then several years after, there's the development of cognitive issues sufficient enough to be qualified as dementia. Whereas in dementia with Lewy bodies, the onset of the cognitive issues either occurs at the time of the motor impairment, before or within 1 year after that motor symptom has started. So if there's, for example, a resting tremor that starts in 2010, but there's not cognitive problems until 2014, that's very unlikely to be dementia with Lewy bodies. If it's 2010 of the onset of the resting tremor, but in 2009 there were some problems with memory or with word-finding difficulty, that's more likely to be a little bit concerning for dementia with Lewy bodies. So that's the summary of my talk for now. I want to thank you all. I will be here for questions and answers later, and I will give it back to Dr. Dial-Edwin. Thank you all.